Hello, 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 hello.
For sure. Paralytics, that's, you know all about these.
Oh, yeah, that's my name. Because if you take out
They had to give me
okay.
I guess I still.
Evening, everyone. Hope your break was stellar. Yeah, it's kind of nice too. So we are on paralytics today. We have some people joining us via Zoom. We have people who are sick. There's something going around. I have, not able to come to class today because of the. That's not terribly clever. Very good. Everybody have a handout? Yes, good. Right. Start. Please pray with me, Father. Thank you for today. We pray that you would supersede over this class and you help us to learn. We pray for those who are ill. Please help them to get better. Those of us who are not ill, please keep us from getting ill. Thank you for this time and please help us stay awake. Amen. All right. Paralytics are used during surgery, but they also get used in the ICU. They get used in the ICU, say if you want to intubate someone, or if you want to put in a G-tube or a central line or something like that. Paralytics might be necessary. When you do something invasive or semi-invasive, patients, even if they're sedated, will tend to twitch. And if that twitching, say you're putting a needle in or something like that, twitching, of course, makes it really hard to do. You would use paralytics. So paralytics work at the neuromuscular junction. So if we use our little blackboard here, and the shadows on here are tremendous, but we'll do the best we can with what we have. So you have a motor neuron, and that motor neuron axon terminus is going to synapse with. All right, let's try this again. Okay, come on, come on. All right, so this motor neuron has the axon terminus. The axon terminus has these are voltage gated calcium channels. And your action potential comes down here like this. Inside this, you have lots of these vesicles that are filled with neurotransmitters. What's a neurotransmitter that's used by a motor neuron? Guys, you have to speak up. I can't hear you if you mumble. Please speak up. Is it epinephrine? Is it norepinephrine? Is it glutamate? Who thinks it's glutamate? Who thinks it's norepinephrine? Who thinks it's GABA? Anybody have any ideas? All motor neurons release acetylcholine. Acetylcholine. So in the muscle, you have this specialized structure. Anyone remember what that's called? That's called the motor. Fill in the blank. What's it called? Motor end plate. Motor end plate. Now, oh goodness, that's sideways and you can't see a bloody thing, can you? There. A little bit better. There. There. Now you're not looking sideways. Okay, so these motor end plate membranes are decorated with these ligand-gated channels. These are your nicotinic acetylcholine receptors. And your paralytics are going to work at these receptors. This is what they're going to deal with. So these are ligand-gated channels. They bind the ligand is acetylcholine. They open, they let cations into the cell, and they depolarize locally. And also in this membrane, there are voltage-gated sodium channels. And eventually, that depolarization spreads to the whole membrane, and the muscle then is able to contract. So that's your target. These receptors are going to somehow gum this up. That's where they're going to work. These drugs, rather, they're going to target those receptors. So this is drawn a lot better than I could draw it, but as you can see there, the motor neuron is releasing acetylcholine. It binds to the nicotinic receptors. And there's going to be two types of these paralytics. Non-depolarizing, and depolarizing. Non-depolarizing and depolarizing. Non-depolarizing bind to the receptor and prevent it from being able to bind acetylcholine. So the receptor stays shut and the muscle stays unactivated. So that causes paralysis. The other are the depolarizing ones, and the way they work is that they bind to the receptor and it opens, and then the muscle gets really depolarized, but it gets so depolarized it can't go back to normal, so it just stays depolarized. And those are the depolarizing ones. Those are the two main types of these paralytics. So they prevent muscle depolarization, two classes, non-depolarizing and depolarizing. There is one depolarizing paralytic, and that's succinylcholine. And succinylcholine is definitely the most widely used of the paralytics, bar none. Bar none. The non-depolarizing paralytics, you see you have your pick of the litter. You have pancuronium, rocuronium, atracurium, vecuronium, cisatracurium, and Curaring. Notice each and every one of these has C-U-R in their name. You see C-U-R in the name, it is a non-depolarizing paralytic. It's not uncommon in surgery to start with a non-depolarizing paralytic and then transition to succinylcholine, because succinylcholine takes longer to work. Succinylcholine, however, does a pretty good job in recovery. Of these non-depolarizing paralytics, the ones that get used the most are rocuronium, the second one there, vecuronium, the fourth one down, and then cisatracurium, the 1, 2, 3, 4, 5, fifth one down. Those are the three that get used the most. So these are administered intravenously. The non-depolarizing paralytics antagonize the receptor. The receptors fail to open. You don't get depolarization of the muscle cell. And they work in just a few minutes. They start with the face and then the fingers and the larger muscles of the neck, torso, limbs, and then finally the diaphragm. And then the recovery is in the reverse order. So here's the sequence. You'll usually start out here. And when someone is going under, that's one of the first things you test is you do the fingers. Then it'll go usually to the face, the eyes, the orbits, then the limbs, then the trunk, then the laryngeal muscles, intercostals, and then the diaphragm. And then recovery goes backwards. So the first muscle to recover is the diaphragm. Now, intercostals and diaphragm are going to be paralyzed. What's this patient going to need while they're on a paralytic? Breathing tube. You're going to need to intubate them. They will need to be on a respirator. And if you're going to use this stuff in the ICU, you need to either have the help to hook them up. Most ICU nurses know how to hook people up to a respirator. Or you need someone who's really good at it if you don't feel that confident doing it.
Do you like in them like while they're going under or like before or like?
If you're going to intubate them before the paralysis works, usually you sedate them. You also give them usually some fentanyl, because having a tube down your throat doesn't feel very nice.
Yeah, that's what.
So you sedate them and usually give them fentanyl, and then you intubate them and then you start sequence. Or usually, because the non-paralyzing ones work so fast, you can do it while you're intubating. That's possible too.
Is this like what you do when you put people in medically induced coma? Like what? Drugs you use, or-
Medically induced comas are usually with barbiturates. And in cases like that, because you're depressing the central nervous system, you typically will need to intubate.
Right. I just didn't know if
You may not, but usually you do. Usually you do. The other advantage of integrated is you can adjust the PCO2. If you're trying to decrease intracranial pressure, adjusting the PCO2 is really useful. So that's the other advantage of integrated. Now, of these drugs, atracurium is the worst. Consequently, it's not used that much. So atracurium induces histamine release from mast cells. So it'll cause very bad bronchoconstriction, and it'll cause vasodilation, therefore causing hypotension. That hypotension will cause reflex tachycardia and flushing or reddening of the face. Also, it gets metabolized into a molecule called laudanacin. Laudanacin is toxic. And if you have a patient with compromised renal function, if it builds up, it'll cause seizures. For that reason, atracurium is not used that much, but cis-atracurium, which is an enantiomeric cis isomer of it, produces much, much lower amounts of laudanacin. So that's the one that's typically used, not so much the racemic mixture atracurium. So what will these cause? They may cause nausea. Some people, of course, don't tolerate them well. They wake up, they feel sick. Some vomiting, maybe some swelling, maybe discomfort at the injection site. Sleepiness or lightheadedness, itching. About 5% of people probably get itching. Some people even get a skin rash that goes away. And then usually the blood pressure can bounce up or bounce down. So the patient needs to be watched. To reverse your non-depolarizing paralytics, you can use a cholinesterase inhibitor. That cholinesterase degrades acetylcholine. This essentially takes acetylcholine's levels and bumps them way up. So neostigmine inhibits degradation of acetylcholine by cholinesterase, and that is a very good reversing agent. The other reversing agent is this agent, Sagamidex. Sagamidex, as you can see, is a dextrin, and it essentially binds the drug and prevents it from working. And it's particularly good with rocuronium and vecuronium. So those are the reversing agents. Questions about the non-depolarizing paralytics? Big thing to watch with these is breathing. Make sure the ventilator is adjusted properly. If you don't adjust the ventilator properly, you can blast out somebody's lungs. So make sure the airflow is just right. The depolarizing neuromuscular blockers include succinylcholine. So this will mimic the activity of acetylcholine, but it's not degraded by cholinesterase. So you get two phases with this. You get the prolonged depolarization phase. You'll actually see muscular fasciculation in the first phase. And then once the motor end plate, nicotinic receptors become desensitized and shut down. Now you have the second phase, that's a desensitization phase. Now the patient's paralyzed. So this is administered intravenously. Starts to work pretty quickly, less than a minute. It'll last for less than 10 minutes after you shut the drip off. It leaks into the plasma and it's degraded by the enzyme pseudocholinesterase. 1 in about 4,000 people. It depends on the ethnic heritage of the patient. So it could be as much as 1 in 3,000 to 1 in 4,000 have a mutation in the gene that encodes pseudocholinesterase. These people will end up being paralyzed by succinylcholine for up to an hour. And if that's the case, you don't use succinylcholine. This is called pseudocholinesterase deficiency. You find it at high levels in Persian Jewish communities and in Native Alaskan communities. That's where you find the highest levels of it. And that means if you find a patient who's got this, you're going to need to support their breathing. They're going to need to stay on the respirator for as long as it takes.
So are paralytics like used in partner with anesthesia, or like how's it
Yeah.
come into play?
Anesthesia doesn't paralyze you. The paralytics, particularly for invasive surgery, really of any type, you use a paralytic. And they're also used med-surg under certain conditions. You come in, say you're med-surg, you come in, give the patient their 2 o'clock. Can't breathe. They're allergic to the drug. No one knew they were allergic to the drug. There's nothing on the chart. You had no idea. You either do a trach right then and there, or you put a tube down their throat. You put a tube down their throat, they're not going to cooperate. Just saying. So you gotta hit them. You have to sedate them, paralyze them, and give them a paralytic. Succinylcholine can cause malignant hyperthermia. It's not common, it's rare, but if it happens, it's life-threatening. And remember, we saw this with the inhaled anesthetics. The treatment for it is dantrolene. And if you have succinylcholine around, you will always have a malignant hyperthermia crash cart. Same thing with inhaled anesthetics, with the exception of nitrous oxide. Nitrous oxide doesn't cause malignant hyperthermia. The others do. Isoflurane, sevoflurane, thiopental, so on and so forth. Question 1. After paralytic administration, which muscle recovers the fastest? Diaphragm. Diaphragm. Very good. What medication reverses the effects of non-depolarizing neuromuscular blockers? What? No, it inhibits cholinesterase. Neostigmine. Neostigmine, what's the other one? Sagamidex. Sagamidex. Very good. Atracurium is converted into what neurotoxin that causes seizures if it builds up?
I don't know, is it the one that starts with an L? Like,
Yeah. Laudanacin. 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 Question 4. Ambulance brings a young mother, her name is Monica, into the emergency department after a terrible automobile accident. She has flail chest, so several ribs are broken, so the chest cavity can't expand. She has to be intubated. What paralytic will be used under such conditions to get the respiratory tube into her lungs? You want something that works fast? Succinylcholine. Succinylcholine. In the ED under such conditions, it's usually succinylcholine. If you're going to use succinylcholine, what's going to be close at hand? Your dantrolene crash cart. Yes, it's rare, but you're a nurse. You have to be prepared for rare, right? You have to expect the unexpected, especially in the ED. All right, so if we take the handout, which of the following muscle groups demonstrates the earliest recovery from neuromuscular blockade following administration of an anticholinesterase agent? Earliest recovery. Diaphragm. Diaphragm. You think I'm trying to send you a message? B. Janelle, can you read B for us, please?
Yes. A 58-year-old woman with a diagnosis of myasthenia gravis underwent a laparotomy. Her anesthesia consisted of thiopental, nitrous oxide, fentanyl, and oxygen with enteronium as a muscle relaxant and a total dose of 1 milligram. During the procedure, the patient received an intravenous dose of gentamicin. The patient remained apneic at the end of the procedure. The cause of apnea could be ascribed to all of the following except thiopental, myasthenia gravis, pancuronium, fentanyl, or gentamicin.
All right, what's myasthenia gravis? Ring any bells from last year's pathophys class? I'm sorry? No, you didn't have Hashimoto's thyroiditis or Graves' disease. Yeah, Graves' disease. Same pathophys, but not strongholded. Here you make antibodies against the nicotinic acetylcholine receptor. And that immune response will tend to destroy the muscle end plate. So the weakness is first seen usually in the eyes, and then in the face, and then it extends to the limbs. So there's muscle weakness. Now, gentamicin is an aminoglycoside antibiotic. Aminoglycosides can cause neuromuscular blocks. Giving this patient gentamicin was a mistake. That was a mistake. Do you know what it means when it says she was apneic? It means she's not breathing on her own. So she has weakness. The intercostals are weak. She's received something that's already suppressing respiration in the form of fentanyl. They're weak to start with. She's got pancuronium, and she was given thiopental. Which of those is not playing a role in the apnea that she's experiencing? This thiopental, what's thiopental? No, you're ready to say something.
No, I don't.
It is an inhaled anesthetic. An inhaled anesthetic. The thiopental cause respiratory depression. No. No. So the B, C, D, and E all are contributing to her lack of breathing. Thiopental is not. All right, any questions about the paralytics before we move to something else? Yes, Paige. Gentamicin is an aminoglycoside antibiotic. Aminoglycosides can cause neuromuscular blocks. So if you use them with paralytics, they will potentiate the effect of the paralytic. And now, as the saying goes, for something totally different. Now, when we talk about demyelinating diseases, multiple sclerosis is the one that you encounter the most. Also, most demyelinating diseases are treated with steroids, but multiple sclerosis has drugs designed just for it. And these drugs are, the way they work is pretty complicated. So that's why I'm dedicating an entire section to drugs for multiple sclerosis. Okay, where's Morgan? Oh, she's going to come on. So multiple sclerosis is the most common demyelinating disease. It's an autoimmune disease. That means that demyelination occurs because the immune cells, the B cells, the T cells, and the macrophages attack myelin. The T cells get through the blood-brain barrier, and once inside the brain, they're activated by myelin. Multiple sclerosis is a type 4 hypersensitivity, a type 4 delayed type hypersensitivity. So these myelin sensitized T cells, they release cytokines. Those cytokines dilate blood vessels. That allows more immune cells to get in. And these will damage the cells that make myelin. Those cells are oligodendrocytes. The cytokines will attract B cells. B cells will make antibodies that mark the myelin. And then when macrophages come in, they see the antibody marked tissue and they attack the marked oligodendrocytes and destroy them. Without oligodendrocytes, there's no myelin to insulate the axons. You get scar tissue instead that leaves plaques. The immune attacks will tend to happen in bouts, and then regulatory T cells will inhibit the inflammatory process until the next time. Early on in MS, the oligodendrocytes will heal and they will make new myelin to cover the neurons. That process is called remyelination. Over time, the damage gets bigger and bigger and bigger and is irreversible. The cause of MS is not known. It's linked to both genetic and environmental factors. Females are more likely to experience it than males. Certain types of HLA alleles are known, particularly class 2 alleles, are known to increase the risk of experiencing multiple sclerosis. Infections like Epstein-Barr virus infections can increase the risk of MS, as can deficiencies for vitamin D. And this seems to explain why MS rates get higher as you go further away from the equator, because you get less sun exposure, less vitamin D, and so on and so forth. Bless you. Usually one of the first place you see MS manifested is in the visual system. You get decrease in the field of vision. You also have problems with eye movements. So one of the first things that people will usually report is diplopia. Diplopia is double vision. The other thing you will notice, particularly when you ask the eye to abduct, is nystagmus. Do you remember the lab you guys did in A&P? You spun each other in the chair? And then you stopped, you stopped, when you stop, the eyes keep going. The eyes go rip, 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 like that. You remember that experiment? That's an example of motion-induced nystagmus. In this case, you have damage to the optical machinery. And so when you're doing a head to toe, when you ask the patient to hold their head still and look at the eye, at the finger, the eye will go out like that, and then it will start to quiver like that. That's nystagmus. That's usually one of the first things you'll notice with multiple sclerosis. All right, so you also usually get problems with sensation. You can get loss of sensation. You can also get exaggerated sensations sometimes. So there is a particular phenomenon. It's called limidicine. With this sign, the patient, usually you just have them bend forward. When they bend forward, they get an electric shock that goes down their back. The other feature is something called Uthoff's phenomenon. I'm going to spell this right because this is spelled really strangely. So this one is something that you see where the symptoms get a lot worse when they get in the shower. The hot water all of a sudden makes their symptoms a lot worse. So when you do a head to toe, the big three for MS is what's called Charcot's triad. There's an R in there, Charcot's triad. You are going to see unclear speech, dysarthria. Dysarthria, then you will see nystagmus, involuntary rapid eye movements. Dysarthria, nystagmus, and then intention tremor. Intention tremor is usually due to damage to the cerebellum. They don't have a tremor at rest, like you see with Parkinson's, but when they want to do something, then the shakes will usually start. Sorry?
What's dysarthria?
Unclear speech. Unclear speech. So there's different types of MS. The most common is relapsing remitting MS. Relapsing remitting. And I think the picture here does a pretty good job of showing you that you get an attack of MS and then it remits. And you can have a pretty long time sometimes between another attack. Then you get another attack. And then after a while, you don't go all the way back to where you were. There's some permanent damage. You notice loss of sensation or loss of abilities or something like that. And so you have these periods of stability. So the goal of treatment is to decrease the number of episodes. Relapsing remitting. Secondary progressive MS starts out usually as relapsing remitting. And over time, the symptoms and the functional decline start to become continuous, hence the straight line you see there. Primary progressive, instead of having the attacks and then the return to baseline, you just kind of just get worse and worse and worse and worse and worse and worse and worse. Symptoms kind of worsen continuously over time with primary progressive. About 15% of people with MS are diagnosed with primary progressive. And then you have the so-called clinically isolated syndrome, in which you get symptoms that last for about 24 hours, and then usually they go away. This might be the start of MS, or it might not affect you the rest of your life. It's very hard to say. All right, so diagnosis is with MRIs, and with MRIs, you can see the plaques that are a result of demyelination. They kind of look like little fingers. They're near the ventricles usually. You can see them here. These are sometimes called Pierce fingers. Pierce fingers. All right, so the treatments start usually, you usually start with steroids. But again, you don't want someone on steroids for long periods of time. You can get Cushing disease, and you just really don't want to go there. So the first drugs usually that are tried are the interferons. So these are interferon betas. These reduce clinical relapses by 30 to 35%. They can cause injection site reactions, and people on interferons can feel really yucky. They can feel like they have a flu. Some of these have to be injected once every 2 weeks. So, for example, this one, Pellegrini has to be injected every 2 weeks. Some have to be injected every other day or even once a week. So Avonex has to be injected. Where did you go? There you go. This one has to be injected every week. So depending upon the formulation, the injections, usually you can teach people how to self-inject. Interferons are used a lot. They're not cheap. So a year's supply of interferon is 81 grand. Not cheap. That is a year's supply. That's still a lot of money. Glitazone acetate is probably the safest of the MS drugs. It's very well tolerated. What glutaminyl acetate is, it's a bunch of short polypeptides, and what they appear to do is keep the immune system busy. That's more or less what they do. Has to be injected once daily or at least 3 times a week. Glutaminyl acetate is safe during pregnancy. It's excreted in breast milk, but it's clear that the peptides are degraded in the belly of the kid, so that it's safe during lactation as well. Very well tolerated, very safe drug. You get about a 30% reduction in flares. So it's not the most effective drug, but it's well tolerated. Those don't work, then usually you go to the biologics. The biologics have to be injected. And the big gun, the drug that works the best, is this one here, natalizumab. The trade name is Tisabri, but it's been available for so long that, well, no, according to medical letter, it's still Tisabri, but so this one will give you about 70% remission. It's very effective. This drug has some caveats, though. We'll talk about those caveats right after we take our break. So take 5. Come back rejuvenated. Yeah.
The disease courses, is there a certain order that they happen in? Is it just kind of
Most people
classified?
start, right, most people start with the, it's rare for someone to not start as that. The progressive one, even the progressive MS, primary progressive. There are people who start as primary progressive, but they're in the minority.
So they don't, like, it's not really an order, it's just classified what.
Yeah,
they
yeah,
start
and
there,
also
but-
the treatment that you give, if you only got primary progressive, you have to keep them all. Usually with the relapsing remitting, you push them into remission using the steroids, and then you treat them to keep them in remission, and that's what you're trying to do. You're trying to keep them in remission, decrease the number of flares, or if they have a flare, you're trying to make sure that that flare is not very bad.
Well, I think you changed this, yeah. Yeah.
Thank you.
Oh, yeah, you definitely deserve this. Yeah. Yeah. Wow, what a way. Yeah. But, I said no, so. Yeah. Oh, but I was like, oh. We go to Tennessee. Yeah, we leave Thursday. And then it's back to back meetings. Basic, we have a break at Easter. Because they don't schedule us. There's meets available.
You'll be here.
Yes, I'll be here. Yeah, I won't miss this. Yeah. But then we have our home meeting first. At the end of this month. The 31st first. It's not. Oh, very cool. Yeah. But I went last year. Right? Yeah. Speaking of that, I mean, we found that we did.
Yeah. Don't you, Karen? Yes. Okay.
I know I'm not.
Yeah.
Okay.
Yeah. Like trying to say that I know it's like story here, but and so he didn't like he just wanted to know like if somebody said it was
But he's like sexuals, if we could have gone to Texas, Tennessee, Illinois, or Ohio.
like it's
Or like, I
don't want to say
Are you getting slung at Florida?
the retirement money.
You guys think?
Oh, I didn't see that. Wow. Yeah. The money I you know, that house will be anything.
Yeah, that's all. We got it down.
Right.
Yeah, that's my fire. That's like my prison. They took it.
Yeah.
They were timid. The quizzing, they were timid. Other teams. Okay, gang, it's time to get back on the horse and ride once again. So did you get the link? No? All right, so there are also pills that are available if patients don't like taking shots. So let's go on, let's take a look at each of these different medications. So some things to teach patients with multiple sclerosis. So because they lose their sense of temperature, one of the best things they can buy is if they take a bath, is a thermometer for the bath. Make sure the bath water is not too hot, because they can get in the bathtub and it can be really hot and they can not know it. They could burn themselves. So control bath water temperature. Because swallowing can be an issue, they're more prone for upper respiratory infections to become lower respiratory infections. So they need to stay away from people with upper respiratory infections. They need to have assistive aids. So if they need walkers or canes or something like that, they might need devices that occupational therapists can design to help them put their socks on or something like that. And because incontinence tends to be an issue, have them use incontinence pads. All right, so steroids are usually used to drive flares into remission. The treatment then is meant to keep them in remission. So the steroids are usually meant short-term. And for that, they're pretty effective. But again, you don't want people to be on steroids for long periods of time because of the adrenal gland suppression and Cushing's disease and so on and so forth. So the interferons, as we said, they can cause injection site reaction, flu-like syndrome. The pegylated interferons last longer. They can be administered either subcutaneously or intramuscularly. Something you guys will have the option to do. There are patients who just really hate needles. They don't like to give themselves injections. You may get a call from Mrs. Collins at church saying, Catherine, can you give me shots of this stuff every week? I'll pay you. To which Catherine says, no, you're not going to pay me. I'll do it for free. Now, she may end up paying you after a while, in which case, as you've taken time out, you may accept it. But if she's on Medicare, you have to take it, put in the church offering, and then the church uses that to drive the places and things like that. So that is something that nurses often get calls for. I don't like needles. Can you please come give me shots? I'll pay you a little something. Nice little side venture in addition to your, shifts that you work and so on and so forth. So the interferons, they come in 3 times a week, once a week, once every 2 weeks. Interferons are safe for pregnant women, and they're safe during breastfeeding. There's a lot of research showing that. The glutamate acetate, it has about the same effectiveness as interferon, maybe a touch lower. Very safe, very well tolerated, very safe also during pregnancy and during breastfeeding. So natalizumab is an monoclonal antibody that binds to integrins that immune cells use to access the central nervous system. Because those integrins are blocked, essentially what you've done is you've shut the door to the central nervous system and locked it, so that the immune cells cannot access the central nervous system. That's how they prevent the flares from occurring. This drug is very effective. It's given by IV infusion over an hour, and it's given once a month. That means the patient will have to come to your clinic in order to get their natalizumab. So you'll have to hang. It comes in a bottle like that, and you'll literally either hang it and use a piggyback to give them fluids, or you'll just give them the natalizumab and you infuse it over an hour. Very effective, 80% reduction in enlarging brain lesions. 40% decrease, progression rate decrease, reduces relapse rates by 70%. The big problem with this drug is this. You have the risk of this phenomenon called progressive multifocal leukoencephalopathy, PML. So the John Cunningham virus, the JC virus, is a small DNA virus that all of you in this room have probably seen before. Your immune system usually keeps it at bay, and it's not of any consequence. If you're on natalizumab or other drugs like it, the JC virus can enter the central nervous system, and it can infect the brain, and it can cause encephalopathy. And your immune system can't fight it because you're taking a drug that prevents the immune system from getting to the brain. So the risk at first is very low, 0.02%. As you continue on natalizumab, the risk increases. Because of that risk, you have to watch patients on natalizumab. And you cannot give them any other immunosuppressive drugs. That is a must. That is a must. The prominent symptoms of PML are paralysis, clumsiness, progressive weakness, vision loss, impaired speech, cognitive deterioration, and personality changes. If you give the patient a blood test, you will detect antibodies against the JC virus. You will also detect JC virus if you do a lumbar puncture. This virus also attacks oligodendrocytes and destroys them. So this is the big downside to natalizumab. Very effective drug, but you really have to watch for this progressive multifocal leukoencephalopathy, PML. And usually because natalizumab keeps people pretty even-keeled, all of a sudden they start getting symptoms. You pull the drug right away. You pull it right away, and because they probably have PML. Safe for breastfeeding. Pregnancy, the data are conflicting. So what's your policy? On which side do you err? Safety, always. Always. Safety, always. Unless your patient's going to die. Questions about natalizumab? Another injected anti-MS drug is this other antibody, alemtuzumab. This depletes B and T cells that have this surface protein called CD52. This drug is more effective than interferons. It's given as a daily IV infusion for 5 days. And then you don't have to treat it, give them anything else for a year. Very convenient. Very convenient. Not safe for pregnancy, but it is safe for breastfeeding. Antibodies too big to be secreted into breast milk. It can also cause serious autoimmune reactions, and it increases the risk of malignancies. So FDA recommends that alemtuzumab only be given to those who've had suboptimal responses with at least 2 other agents. Then you have the anti-CD20 antibodies. CD20 is a protein found on the surface of B cells. This will therefore delete those active mature B cells that are ready to get after your CNS. There are 2 of these, ocrelizumab and ofatumumab. Who names these things? So ocrelizumab is given twice a year by IV. Ofatumumab is given once monthly and is given subcutaneously so the patient can self-administer it. Comes in injector pens. Ocrelizumab is approved for primary progressive MS, only approved drug for primary progressive MS. These drugs also have the risk of PML. You might also get the multifocal leukoencephalopathy, peripheral multifocal leukoencephalopathy with this one. So you want to watch for that as well. Rituximab is an older anti-CD20 antibody and it's cheaper. And there are biosimilars and that makes it relatively inexpensive. So this is a less costly alternative to ocrelizumab and ofatumumab. PML has been observed in people on rituximab, but that's usually in people on rituximab and something else, because rituximab is also used to treat leukemias. This drug was just approved end of last year. Obinutuzumab, and this has been approved for the relapsing forms of MS. These drugs all increase your risk of infection, particularly upper respiratory infections. You might also get infusion reactions with them. You might get a fever or chills or a headache or something like that. Mitoxantrone is an old drug. It's an anti-cancer drug. This drug is cardiotoxic. It's been associated with the onset of leukemias. It's also not safe during pregnancy or breastfeeding. Use of this has declined because of concerns over long-term effects of this drug. So this drug is definitely second tier. Having said that, it's cheap. Let's see. Year supply is $1,400. Compared to the antibodies, that's really cheap. Let's look at the prices of the antibodies, shall we? Prepare to be amazed. Natalizumab, a year supply is $97,000. Oh, Medicare. Ocrelizumab, a year supply is $67,000. Ofatumumab, a year supply is $83,000. Rituximab, a year supply is $9,000. You can see why rituximab is being used. It's a much cheaper alternative. Oral drugs. So these drugs block the sphingosine 1-phosphate receptor. Immune cells use that receptor to access the central nervous system. And that's how these oral drugs work. All of these drugs end in IMOD. IMOD. So there's fingolimod, siponimod, ponesimod, ozanimod. Those are all oral treatments for MS. These drugs are more effective in clinical trials than interferons if you test them head to head with interferons. They are not safe during pregnancy. They cause fetal toxicity. They've also been detected in breast milk. And so you shouldn't use them in lactating mothers either. These drugs have some drug-drug interactions to consider. So siponimod, for example, is a 2C9, cytochrome P450 2C9 substrate. If you use it with inhibitors or inducers of 2C9, that can affect the levels of that drug in your body, so that drug-drug interactions are a concern with that particular medication. Cladribine is an older drug. It depletes B cells, and it is used in patients who either don't tolerate or can't use other drugs. This particular drug is contraindicated in women who are pregnant, wanting to become pregnant, or breastfeeding. It can decrease your lymphocyte numbers, and it can increase the risk of malignancies. Having said that, it is an older drug and it's relatively inexpensive. Well, it's not that cheap, actually. Okay, well, so yeah, it's expensive. There are a series of oral drugs that are fumarates. These fumarates are antioxidants that essentially prevent the immune system from working. There aren't a lot of good comparisons between this drug and some of the others. It's easily as effective as glutaramine acetate. It's more effective than this other drug we'll talk about, teriflunomide. PML has been reported, but not at very high rates. People who start taking it seem to get some GI issues. That tends to go away. When it comes to women pregnant or breastfeeding, there's just not enough data. So to be on the safe side. Teriflunomide inhibits the synthesis of pyrimidines, and it reduces B and T cell proliferation. This drug is a cytochrome P450 1A2 substrate. So it'll increase the concentrations of oral contraceptives. This drug is less effective than the fingolimod and other drugs like that. It's also less effective than dimethylfumarate. But it's oral, so it's easy, and if all else fails, there you are. You might want to take note that these medications, if someone gets COVID-19, they are at higher risk of severe disease if they're on these medications. These medications do suppress the immune system. So that's something to keep in mind. Any questions about the MS medications? They are complicated. All right. In the fleeting amount of time we have left, let's talk about something completely different. And that is the treatment of headaches. So headaches, very simply, are terrible pain in the head and neck. There are the so-called migraine headaches, tension headaches, and cluster headaches. Migraine headaches, tension headaches, and cluster headaches. You can also have headaches from head injury. So tension headaches, very simply, are usually due to, if you're leaning over something, you get a lot of tension or stress, you can tend to, tighten up like that. That can tend to precipitate a headache, tension headache. Tension headaches are the most common primary headache. Pain's mild to moderate, lasts a few hours usually. There are usually no associated symptoms with a tension headache. They're triggered by stress, lack of sleep, your pharmacology professor, things like that. Migraines are the second most common primary headache. Some of you may know people who get migraines. Maybe some of you suffer from migraines. They can be quite debilitating. The theory of how migraines are produced is a little bit controversial, but what seems to be the case is that the trigeminal nervous system is activated. You get this wave of activation that is serotonin based that flows over the brain. This wave of activation can cause things like auras, and they can actually decrease your ability to talk or even respond properly. I don't know how many of you know Chuck White. Chuck White actually is prone to migraine headaches. He was sitting in that office one day, and I told Chuck hi, he could not speak. When he gets migraines, he can't talk. He just was able to go. That was it. I had another student, oh gosh, about 10 years ago now. Literally her eyes would just start to go kind of half mast, and she'd just stare straight ahead. And I could tell at that point in time she was having a migraine. Now, this poor gal, she had lots of different treatments, and no matter what she did, it didn't help. She eventually got that dealt with, but boy, for a while there, it was terrible. So one of the things that gets released, so you have serotonin. Serotonin causes pretty massive vasodilation within the head. That vasodilation puts pressure on the meninges. That causes pain. And then you have a molecule that is released called the calcitonin gene-related peptide. Calcitonin gene-related peptide seems to be responsible for much of the physiology of migraines, along with serotonin. So when it comes to treating migraines, many of the agents are going to block serotonin receptors in the blood vessels, or they're going to deal with this. I don't see it on there. Oh, there it is. Calcitonin gene-related peptide. That's where a lot of them are going to go. Once migraines are over, people can be sore and they can be very fatigued. It's not uncommon for people with migraines to have nausea and vomiting. And also have photophobia. They have to spend time in a dark room or something. You'll see sometimes students who will come to class with sunglasses on. They may be people suffering from a migraine. So go easily on them. So usually things that work for tension headaches, like aspirin and acetaminophen and ibuprofen and things like that, don't touch a migraine. Now there is a very powerful NSAID called diclofenac. We talked about that. It's available in a powder. This powder form has a very rapid onset of action, and it can be used to treat a migraine. Some people get relief from it. A lot of people don't. Celecoxib has been approved for migraines, but most migraine sufferers I've talked to say it doesn't work. But the FDA approved it. You can also buy products that have this stuff called butalbital. Butalbital is a barbiturate. You'll have butalbital with caffeine or something like that. They're marketed for migraines, but pretty rigorous head-to-head studies of this drug with other drugs shows that this drug doesn't work. So save your money. Also, butalbital, it's a barbiturate, it's habit forming. So that's another reason to stay clear of it. Doesn't work, habit forming. Survey says, just stay away. You get patients who are using that stuff, tell them, don't use that, there are better medicines for it. Let's have you see the doctor will prescribe something that actually works. What do you do during pregnancy? Butalbital is not safe during pregnancy. Neither are NSAIDs, but acetaminophen is. First line drugs for migraines are these drugs called triptans. They all end in triptan. Almotriptan, elatriptan, provatriptan, naratriptan, rizatriptan, sumatriptan, zolmitriptan. These drugs are serotonin receptor agonists. They generally will give you pain relief within 30 to 60 minutes of onset of symptoms when you take it. Naratriptan and provatriptan, these two, you can see They are longer acting, but they take longer to work. These are also better tolerated than the others. And if patients don't respond to one triptan, you can usually have them try another. Very often they will work. So you can mix and match these drugs. Sumatriptan, as you see, comes not only in tablets, but also in a sub-Q injection, and also in a powder and in a nasal spray. Zomatriptan also comes as a nasal spray as well. So nausea or vomiting can affect taking oral triptans because people will just upchuck them. The intranasal formulations get around that, and the intranasal formulations act faster, but they don't last as long. About 20 to 40% of people who take a triptan will get recurrence within 24 hours. Recurrences may respond to a second dose of the triptan. So these drugs can cause substantial vasoconstriction in some people. They can substantially raise blood pressure. So tingling, flushing, dizziness, drowsiness, fatigue, feeling of heaviness, tightness in the chest. They occur with all triptans. Sub-Q sumatriptan really causes that. The SC sumatriptan burns as it goes in. So warn the patient. Intranasal triptans can alter your taste. Following triptan therapy, people tend to be very sleepy. Sumatriptan and naratriptan are contraindicated in people with severe hepatic impairment. And naratriptan is also contraindicated in folks with bad kidneys. If you have someone at risk for stroke, seizure, MI, angina, you can't use triptans. It'll raise the risk, make the stroke, whatever, make all that worse. They're also contraindicated in people with certain arrhythmias, like Wolff-Parkinson-White syndrome, uncontrolled hypertension, what have you. Don't use them. Don't use triptans. If you take a triptan, you can't take another one for another 24 hours. And do not take them with monoamine oxidase inhibitors. You run the risk of serotonin syndrome. Most of the triptans are cytochrome P450-3A4 substrates, so don't use them with strong 3A4 inhibitors or things like that. And that's a skinny on the triptans. The triptans tend to work. They tend to work. Pregnancy, a population study done in the Netherlands, not the Netherlands, Scandinavian countries, didn't find any association between triptan use and birth defects. That suggests that they're safe during pregnancy. They're not excreted into breast milk at any appreciable levels, so they seem to be safe for lactation. And we're out of time, so we'll talk about the calcitonin gene-related peptide receptor antagonists next time and go on from there. Next time we'll talk about Parkinson's disease medications, which are also rather complicated. Have a great evening.
Oh.